Before we dive into today's episode, I want you to take a big, deep breath in and out. That's good. It's very good. Thanks to your larynx or voice box, you're able to breathe and eat and talk. When people lose their voice box, which can happen because of cancer or an injury, they lose a lot, including a sense of identity, because each person's voice is as unique as their fingerprints.
I know who it is not to have my voice, and then to get it back, and not having my voice hurts.
That's Marty. He's a larynx transplant recipient. We're going to hear more of his story in just a few minutes. Researchers are exploring how to give voice back to the voiceless with the help of transplant surgery and eventually using a patient's cells to 3D print a voice box of their own. That's ahead on this episode of Tomorrow's Cure, a podcast from Mayo Clinic that brings the future of medicine to the present. I'm Kathy Werzer. Thanks for being with us. We're so excited to have two people who have advanced the science of laryngectomies, or the surgical removal of the larynx. Dr. David Lott is with us. He's the director of the Mayo Clinic Larynx and Trachea Transplant Program. He's also the associate director of Mayo Clinic's Center for Regenerative Biotherapeutics, chair of the Department of Otolaryngology, and a head and neck surgeon at Mayo Clinic in Arizona. Also with us, we are so happy that Dr. Marshall Strom could make it. He is a well-known board-certified otolaryngologist, an ear, nose, and throat doctor, and professor and chair emeritus of the Cleveland Clinic Head and Neck Institute. Doctors, it's a real pleasure. Thanks for taking the time to be with us.
Thank you.
Thank you.
I'm going to start with Dr. Lott, and it's because I do make my living with my voice. I think I know enough about this little organ. It's so wonderfully complex. What do you think people don't understand about the voice box?
Well, I always used to joke that the larynx was the Rodney Dangerfield of the body, for those people that remember Rodney Dangerfield, right? It gets no respect. And I always, even when he would reach his tie, I think he'd be reaching for his larynx. But it's because when it works, it works in a way that we'd never think about it, right? So it allows us to swallow, eat, and drink, all the things that we do on a day-to-day basis, to breathe, to get air into our lungs. And perhaps, maybe most importantly, just from a quality of life standpoint, it allows us to communicate and share a voice and sing and all the things that we love to do that bring beauty into our lives.
People listening, again, probably don't know a lot about their larynx. And so I'm curious as to what can cause disease and injury to it. What are the most common factors? Dr. Strom?
Well, the most common thing would be an upper respiratory tract infection where you all of a sudden get a little swelling of your vocal cords, and two things happen. One, you're hoarse, your voice changes. The second is the larynx is critical in bringing up secretions from your lungs so that you don't get pneumonia. And so that, in terms of commonality, I think would probably be number one, inflammation. Then at the other end of the spectrum, what both David and I spent a lot of our time doing, is treating malignancy. And that is more common than we like, but decreasing, thankfully, as smoking has continued to be on the decline.
So speaking of cancer, there are about, 12,000 people who develop laryngeal cancer every year, evidently. Let's talk about treatment. It can be chemotherapy, radiation, or complete removal of the voice box. And that feels like a very big decision to make, to completely remove the larynx. So could you walk us through how you help your patients, Dr. Lott, make some of these decisions?
Yes, it's an incredibly difficult decision to make and a difficult conversation to have. So not everybody that gets a laryngeal cancer has to have their entire larynx removed. It really just depends on the stage, but it still happens way more than we would want for that to happen. And when you have to make that decision, I think it's really important to be truly informed about what life will be like without your larynx. And so I go through a list and I describe, when your larynx is removed, you no longer are able to breathe through your mouth and your nose. We have to create a hole in your neck, and you breathe through that hole in your neck. And that has implications on kind of societal embarrassment types of things. It has implications on how you smell and taste food, because you don't get that smell going through your nose quite as easily. It can change the way you swallow. It definitely changes the way you speak, although people can still communicate. It's not with a human sounding voice. So that's the first thing I do is have people understand what life is like, how we can improve their lives, but also keeping the big picture in mind, right? Let's get you healthy so you can continue to have these moments with your family, continue your life beyond that. And then we can come along beside you and help you get through these quality of life types of things.
The road is difficult when it comes to trying to navigate the loss. Do you find that patients become reclusive because of these changes?
That's one of the biggest points of feedback that I get from patients is I hear many times from them that I may be alive, but I'm not truly living because of the social embarrassment, because it's difficult to communicate without that human sounding voice. And it's hard, it's a lot of work to communicate in the way that they do. So it's just much easier for people to stay at home. It typically begins by giving up little things, dinners with your friends, going out to hear, you can't go through a drive-through as easily because it's hard to talk. You can't talk on the phone to somebody quite as easily. So there's lots of little things that build up over time. And then over that time frame, people are just kind of reclusive and in their own homes. And, we do have some patients where we go through that list of what their life will be like when they will have a laryngectomy. And believe it or not, some patients choose to die from their cancer, then live that way.
Let's talk then about this move towards transplantation. There have been only a handful of larynx transplants in the world, and you two have done the first and the third in the whole country. So let's walk us through this, if you would, please. Why, to this point, Dr. Strom, haven't there been larynx transplants?
Well, the biggest issue that was out there for the longest period of time is people said this was a non-vital organ. And transplantation does come with some potential issues that are associated with the medications and other things. And a very small percentage will have an increase in the incidence of secondary malignancies. Now, what really turned the corner for me is a personal case. I was a young first-year resident at a time when the only operation that otolaryngologists did was a laryngectomy. So I spent a lot of time with the patient. He was a strong man. The operation went without consequence. In those days, we kept the patient in the hospital for 10 days. At the end of the 10 days, he went home. He'd seen a speech therapist to help guide him with his electrolarynx to begin at the time with learning esophageal speech. And 2 days after he got home, his wife called to tell me he died. She had a party for him, and he was using his electrolarynx. And his friends came up and said, well, from this point forward, we'll call you Robo-Man. The next day, he jumped off a bridge and drowned. That made very clear to me that the larynx was not a non-vital organ. So the larynx has different meanings to different people, but it's clearly, very clearly, an organ that when you don't have it alters your life in a way that most people would not choose.
I can't imagine the preparation that it took for you both to get ready for this transplant procedure. How did you two prep?
Honestly, of all the things, probably the component I was the most worried about were the logistics and making sure all the different parts of the team came together. I have complete faith in the surgical team. So really it was much more preparing, teamwork, making sure everybody was on the same page, and then the execution part of it just went very smoothly.
Research, in my view, is a team sport. And if you pick the best to be associated with you, they're going to put those vessels together perfectly. And so it is a team effort. We both pretty much followed the same path in that regard. Now, having done the first one, the biggest decision that I had to make is that the larynx was significantly larger than the space that it had to go in, because this was trauma and the patient had had a significant amount of scar tissue and prior surgery. And what we decided at the time is to put in 80% of the donor's throat rather than make the throat too tight. And the question was, well, what if that muscle doesn't function? Will the patient then just aspirate? On the other hand, if you tried to limit the amount of muscle that you put in and the suture line was on the tight side, you ran the risk of having a leak, an infection in the face of immunosuppression, and the whole thing falling apart. So in my operating room, there was dissension as to which way to go. And I finally made the decision that, look, I'm going to put this thing in so I know it's not going to leak, and I'll take my chances with what happens with the reinnervation. And that's what we did.
Do you remember the feeling when you were done with that first transplant and it was successful?
I do. And that's when you remember the people that influenced your life. For me, it was two women, my grandmother and the woman that basically raised me. I would always go into her house when I came home, and she'd sit there and take me on her front porch and read me stories in a rocking chair and tell me that I was going to be somebody special. And my grandmother was sort of the same way, but I didn't see her as often as I saw this lady. When you think about that, people influence your life. And I'd have to say those two were certainly the most influential in my formative years. And who knows what I would have done if it hadn't been there with them pushing me to be better and think that I was maybe something special.
Wow. Dr. Lott, do you remember the first time that you did this particular very complex procedure?
Very much so. So yeah, it's one of those life-changing moments where, it's standing on the shoulders of giants like Dr. Strom and those who have gone before you, where this is successful. It can help patients, but we need to start doing it. We need to start getting it out there and helping more patients with it. And so that's where I believe my purpose and my calling is now, from this perspective, is to now bring this out and actually make it more widely applicable so more people can benefit from this.
I just will make a comment. I think that Dr. Lott was kind enough to invite me into the operating room. And only second to thinking of those two women was the joy I had when we walked out together, having been together for all those years, and just being able to rejoice in the moment.
Did you know you were going to bring Dr. Strom in with you, Dr. Lott?
I had hoped. So I know he spends time here in Arizona. And just by the nature of transplant, you really never know when the offer for the procurement is going to come through. So I sent him, he was one of the very first people I texted, and sent him a text saying, "Hey, Dr. Strom, this sure looks like this is going to happen. Really hope you're in town. I would love to have you to be able to come in and be a part of it." And sure enough, he was available and able to come in and be a part of it. And it was just a wonderful full circle moment. And, there was, if you think about kind of the past to some degree, the present and the future, we even had, students that were in there that were doing research in laryngeal transplantation.
We heard from him at the top of this episode, but I want to officially introduce you to Marty. He's the patient we've been talking about. Marty is just the third larynx transplant patient in the country. He's also a cancer survivor. Right now, we're going to play a soundbite from Marty talking about his life.
I depend on my voice. Mm-hmm. That's how I meet people. Mm-hmm. That's how I enjoy people. And I have a 1-year-old granddaughter that I want to talk. I don't want to have to learn sign language and teach it to my granddaughter. Well, I wouldn't have, she could talk back to me, but I don't want to have to do that.
That was about 4 months after the operation. Dr. Lott, can you tell us a little bit more about Marty, how it all played out? How's he doing?
Absolutely. When you're looking at performing a transplant for somebody, especially this early on, and you know that the impact in terms of how well the patient does really has a long-term impact on the program you're trying to build and your ability to help more patients, it was really important for us to find someone that we felt very confident in and confident that could not only do well from a surgery standpoint, but also do well from a human standpoint. And Marty and his wonderful wife, Gina, were just perfect for this. And so Marty had what's called a chondrosarcoma of the larynx, which is a slow-growing cancer that has a really low risk of metastasizing. So it has a really low chance of going to different parts in the body. With that type of surgery, you can debulk it or remove parts of it to try to buy people time so they don't have to live without their voice box. Well, that had gone on for so long for him that his larynx basically just stopped functioning, and people had tried to do other things to reconstruct that. But he went through a phase where he really had no voice at all. He could not communicate.
I went through my first surgery in 2014. And I recovered for 3 months. Then the trach came out, and I could talk. Everything was fine. And then in 2020, when I had my second surgery, things changed. I couldn't talk as well. And then before my third surgery, I couldn't talk at all. I lost my voice completely. And you just can't go to family functions. You can't go anywhere because you're not enjoying yourself. Because I like to talk to everybody in the room. Not just sit in the corner and talk to one person. I like to move around and talk to everybody. But with the trach, it makes it harder to talk. I get tired quicker. And if there's a lot of people in a room, I can't breathe. It changes the way you live. You know, instead of being the life of the body, I'm the bummer. I don't want to be there.
He was able to swallow okay. But part of that is just because his larynx was so scarred, he was really not physically capable of aspirating. So food could not go into his lungs just because everything was so scarred. So if we had done anything to try to improve his airway, more than likely he would have had difficulty swallowing. So his cancer was also growing. It was getting bigger and coming back. So he really had no other choice than to have his larynx removed. He was not okay with that. He wanted to find a different way to live his life without being a laryngectomy.
So my goal was never to have a laryngectomy. My granddaughter changed my mind about a lot of things. When she was first born, I couldn't talk. My voice was gone. And it bothered me. I couldn't welcome it to the world with words. I wanted my voice. And I'm fighting for my voice. And I'm going to keep my voice when I get it. I'm never going to lose it.
That's where his wife actually found us online, found out about our clinical trial, and reached out to us. He matched all of the medical side of things perfectly. But what we liked from the other side, from the social side of things, is not only was he dead set on this being successful for him, for his family, for his grandchild, for his mom, all those different things. He wanted this program to succeed, so he's not the only person who could benefit from this. And he's been like that really ever since the surgery. He bothers me frequently in a good way to say, hey, when is the next one coming? Let's get this going. Let's keep pushing. So he's a really big advocate for that. He says that his voice is about 70% of what he would consider normal for him. When I listen to him, I think his voice sounds outstanding. But again, we know what our voice should sound like. So he says it's about 70% of what he remembers his voice being. And at this point, he still has the tracheostomy tube, the tube in his neck to help him breathe. To Dr. Strom's point, it takes some time for those nerves to really grow in and work to try to get the vocal folds to open and close to allow him to be able to breathe. But he's able to cap the tube every once in a while and breathe with it closed. So he's getting there. It just takes more time from that perspective.
Even though this isn't a fast cure, Marty thinks that everyone who needs this should benefit from this procedure. Let's hear more right now from Marty reflecting on his journey.
A laryngectomy is a death sentence. It's not quality of life. It's not living. It's not enjoying anything. It's a death sentence. And it's not over days, it's only years. But it cuts your life down a lot. And there's stories about people with laryngectomies who haven't wanted to go on with their life. You know, I don't want to read those stories anymore. I want to read positive things. And that's my reason of pushing for not just this type of surgery, a total transplant, but other surgeries that can fix the problem before it gets worse. Because I know how it is not to have my voice and then to get it back. And not having a voice hurts. Having it back, life is beautiful.
This sounds like it was an amazing success. So I'm wondering, why is this option not available to other patients? What has to happen?
As surgeons, we are always very cautiously optimistic. So any day, things can happen, and we want to make sure that we watch him very closely to make sure that he continues to be as successful as he is. But to this point, he's doing just wonderfully. The biggest barriers to this being more widely utilized, I think, are a few different things. So, as Dr. Strom had mentioned before, the immunosuppression is definitely a barrier for a lot of people. But because the immunosuppression has gotten so much better over time, that's becoming less and less. It's a big endeavor. It takes a lot to create these programs, to get them to the point where you can do these and have them become successful, just like any transplant program. And so you have to have a health system or a hospital that's willing to help provide the startup and the resources needed. So I'm lucky enough that I get to work at a place like Mayo Clinic, where they believed in the mission and wanted to be able to do that. And then lastly is the vast majority of people that are candidates for laryngeal transplant are people that have cancer. And so we're working very hard to get to the point where we can do these transplants in cancer patients. And I know Dr. Strom agrees and would have a lot to say about this, but I really think we're probably at the point there now. We just have to be able to do it in a responsible, safe way.
I do believe we're there, and I think Mayo has been a leader in setting up a clinical trial where Dr. Lott has approval to do 10 patients, the first of which was Marty. And so with this being a success, the hope would be there that the next one would be for the most common malignancy, which is squamous cell cancer. And I fundamentally, based on what Dr. Lott mentioned as well, think we're there. I think the reality is that the first transplant, the larynx transplant that was done, was the only transplant that was done for the first time with immunosuppression. We published everything when his larynx rejected so that people would know at 14 years what it looked like. And I was recently asked, well, how did you know when rejection was occurring? And I clearly didn't know. The larynx was too big for the space it was put into. And I was watching it reshape to what was or would have been his normal size. And I thought, gosh, isn't the body wonderful? It's able to reshape an organ that to be its normal size. But as that process of shrinking continued, I began to realize this was chronic rejection. And I didn't understand it early on, and I didn't know enough to intervene early on. I expect that Marty, with a little bit of luck, will surpass 14 years. We know more now. There's no reason that he shouldn't. And if we can give people 14 to 20 years of a relatively normal life, as I say, I think we found the Holy Grail, and I think we're right there. I mean, David's program is set up to be able to make that happen, and he's the person to make it happen, as far as I'm concerned.
How far are we on the road here, Dr. Lott, to improving the prevention of organ rejection, which is a big hurdle? So what are we learning about how to maybe help folks like Marty?
There's a lot of research that has been dedicated to looking at just that, and there are a variety of different ways. So one way is to look at the immunosuppression itself. Are there different types of immunosuppression medications we can give? Dr. Strom did research at looking at maybe you do pulsing of immunosuppression. So you do little bits at a time, and it turns out you get the same benefit as if that patient was taking the immunosuppression every single day. Another set is to look at using the body's own immune system to create an environment where it actually accepts the transplant. And that's through things like immunomodulation, where you can teach different types of cells in the body that are responsible for finding the transplanted organ and trying to reject that. Well, if you can train those cells to find that transplanted organ and say, wait a minute, this actually is normal, call off the dogs, right? Don't reject this. This is our body. And there are ways that people have come a long way in trying and being able to change the way the immune response happens towards transplanted organs. And then the last side, or one of the last sides, is looking at things like regenerative medicine and tissue engineering to help create the organ so that it doesn't have those proteins that the body will look for to reject. So are there ways to remove those proteins before you place it? So the body doesn't see it as something that's abnormal. Can you place maybe a 3D bioprinted scaffold in that the person's body creates its own epithelium and muscle and nerves and those types of things? So there's lots of amazing research into this exact question. And I really believe that if we're not, as fast as things are progressing, we're not too far away from this becoming a true reality where we have a spectrum of things that we can do for patients, where we can tailor make their specific type of transplant or implant according to what they need.
Thank you for opening the door to maybe a discussion about this, because we've done past episodes on this podcast about using 3D bioprinting and how it may ease organ shortages for transplantation. Could you then print a 3D replica of a patient's larynx and almost tailor make that organ for that patient?
So that's one of the benefits of 3D printing, and I'll separate 3D printing from 3D bioprinting and explain that difference. But 3D printing allows us to create a very, very detailed shape that's almost an exact replica of whatever it is that you're trying to mimic. And so from a laryngeal standpoint, we can make an exact replica of that patient's larynx. Which is really important because everybody's larynx is just a little bit different, and that helps define your voice, your function. Again, Dr. Strom had mentioned in his transplant, the larynx was too big for the space. Well, if we can make sure we have the right larynx, we'll have something that fits perfectly into that space. 3D bioprinting, what that does is the same technique. We are able to create that same shape of the larynx, but it allows us to put in other things while we're printing. So we can use scaffolding. So the scaffolding may be something that's permanent or may dissolve over time. We can put in various growth factors that help the blood vessels to grow in, things to prevent infection while that's healing. We can put in stem cells or epithelial cells or whatever type of cell into that, and that's all printed together as one structure. So when we put that in, the body then takes that information and grows new tissue into that organ. So where we are now with this technology is, again, because of the mechanical kind of machine part of the larynx, we don't have a great way to get the vocal folds to open and close. So if you look at the spectrum of patients that we treat, not everybody needs to have their entire larynx removed because the cancer involves the entire larynx. Many times the entire larynx is removed because we don't have a way to fix the hole that we've created. So the cancer may just be on one side or one portion of the voice box, but there's no way to remove that and still have the larynx function properly. So now we can prevent that person from needing a laryngectomy or thereby a transplant or something, to the point until we get the immunosuppression squared away, by just using the scan, understanding what we're going to remove, 3D bioprint an exact replica of that tissue, and you put that in at the time of surgery, and then the body heals that in. There's no need for immunosuppression because the materials we use don't cause an immune response. And if you use cells, it's going to be the patient's own cells or cells that don't elicit an immune response. So it's safe in terms of cancer concern from an immunosuppressive standpoint because the immune system is intact.
How far away do you think we are from having this technology available?
Just a few years. So we're doing the preclinical studies to be able to get that into humans. But to my point earlier is we realized that we can 3D print different molds and things like that. that we then shape structures into those shapes. And we can show that proof of concept that, hey, if we put a new vocal fold structure here, we put in half the voice box here, then people will still be able to swallow, they'll be able to breathe, and they'll be able to talk. It's just that we want to optimize that process so it doesn't take so long to heal and that they get better functional results.
Oh, wow. Dr. Strom, as a person who performed one of the first larynx transplants, what do you think of this idea of 3D bioprinting? Isn't it amazing how far things have come?
It has, but and David, I think, explained that very well. But let me just talk about some other areas that are gaining traction. So the whole idea is to have the body accept the organ as self. So how do you do that? Using bone marrow that you give the patient at the same time that you do the transplant. And in the kidney world, it seems, at least in pigs, that you are able to get tolerance. Certainly in the animals, and I see no reason that you won't be able to get that for the human. But for whatever reason, it works for the kidney, but it isn't going to work for other organs. If you're way out there, like a lot of people think I am, you might just decide to take a little piece of the donor's kidney at the time that you're doing the larynx. It wouldn't add that much to the operating room procedure. Anastomose those vessels, hook up the excretory system to the bladder, and then you have that kidney there at the time, little piece of the kidney that would then enable you to get tolerance when you give that bone marrow transplant. And, I look at that kind of stuff for the future and I think about, well, moonshot, maybe, but people have landed on the moon. And it's like David said, what about tissue engineering? I'm not about to say that those nerves one day we won't be able to get them to regrow in regenerated tissue, because anything is possible if you think it's possible and you keep working at it. The whole object is be able to offer people an organ that will make their life infinitely better if they choose to have such done at the time they require a laryngectomy.
So, Dr. Lott, as we're talking about moonshots, what needs to be done in order to prepare to have a successful moonshot in a sense, right? I mean, more clinical trials?
But you got to build the right rocket to get to the moon.
There's that.
Got to have everything in place.
Right.
So that's the big part of it is having a multidisciplinary team that comes together with a unified vision. And then the next part of it is to be able to safely translate these types of things into patients at various steps. I think one of the biggest problems that we have in medical research is that we have our eyes on the final prize on getting to the moon, but you forget about, well, you've still made an improvement compared to where you were. So can we help patients in between until we get to that point? And while you're doing that, you're learning things, and those are valuable lessons that help you actually get to your final destination. So I think if you get those two things together, then really there really isn't anything that you can't achieve.
Amazing. So can we go back to Marty for a moment to kind of end our conversation? Because he's doing well several months after his transplant, I think we should hear about what he thinks of all of this. So this is Marty.
It's incredible. I don't have to worry about it anymore. I'm a lucky person. I'm lucky I found this hospital. Don't give up. Don't give up. Never give up on life. But I was saying, don't think about yesterday. Don't worry about tomorrow. Live for today. Every day is standing up or waking up is a good day. I'm going to make it the best day, every day. And that's what I try to do. And that's what I'm going to keep on doing.
Never give up on life, that's for certain. I think that is a great way to end our conversation. I've really enjoyed this, gentlemen. Thank you so very much.
Thank you.
Thank you very much. Thank you for your willingness to tell the story. We think it's important, so appreciate that.
Tomorrow's Cure is a co-production of Mayo Clinic and PRX. Our producers are Deborah Balthazar and David Newtown. The show is edited by Genevieve Sponsler. Our sound engineer is Tommy Bazarian. Our theme was composed and produced by Terrence Bernardo. Tony Carlson is our production manager, and our executive producer is Jocelyn Gonzalez. Special thanks to Preston Spire for audiovisual production support. Be sure to follow Tomorrow's Cure wherever you get your podcasts. I'm your host, Kathy Wurzer. Thank you so much for listening.